Welcome to Rad Unc Smart Review CNS Cancer Series. So, over the last few sessions, we've walked through a lot of the core evidence in neuro-oncology. Today, we're going to shift gears a bit and put that knowledge into practice. Think of this as a case-based mock oral board style discussion. We'll focus specifically on high-grade and low-grade gliomas. I'll be presenting some complex cases, acting as the examiner, and we'll work through them together, really integrating the molecular understanding with the level 1 evidence. Ready to jump in?
Absolutely. Ready. Let's integrate.
Okay, let's start with maybe the most common scenario, definitely a challenging one. Case 1. We have a 58-year-old right-handed man. He comes in with about 2 weeks of progressive left-sided weakness, also has headaches, worse in the morning, kind of classic for increased intracranial pressure. On exam, his strength is down maybe 4 out of 5 in the left arm and leg. Karnofsky performance status, his KPS is scored at 80. He's obviously heading towards surgery. So tell me about the initial workup. What imaging do you need? What sequences are critical? And what about immediate supportive care and seizure prophylaxis?
Okay, first step is a really focused neurologic history and a thorough exam. Gotta confirm that baseline deficit in the KPS of 80. For imaging, the absolute cornerstone is a high-resolution brain MRI, both with and without gadolinium contrast, and you need specific sequences. I'd make sure we get T1 pre and post-contrast, obviously, T2 flare. That's crucial for looking at edema and any non-enhancing infiltration, diffusion-weighted sequences, and definitely susceptibility-weighted imaging to check for any hemorrhage or, get a sense of tumor vascularity, and of course, standard pre-op labs, CBC, CMP, that kind of thing. With that progressive weakness, you have to act fast. I'd start dexamethasone immediately, probably dose around 4 to 8 milligrams twice a day, something like that, and absolutely need gastric prophylaxis alongside it. The goal there is just to knock down that vasogenic edema quickly, hopefully improve his symptoms, maybe even bump up his KPS before surgery. But you also need a plan for a fast taper once definitive treatment starts.
Makes sense. What about seizures? He hasn't had one yet.
Right. He's seizure naive, even though, a frontal tumor like this is often in a spot that could cause seizures.
Yeah.
But the SNO and EONO guidelines are pretty clear here. Routine prophylactic antiepileptic, not recommended. The risk of side effects from the drugs, things like hypersensitivity, rash, high it, generally outweighs the benefit of trying to prevent a first seizure. So I'd hold off on starting something like levetiracetam unless he actually has a seizure. But I would definitely counsel him and his family about seizure precautions, what to look for.
Good. That's a really critical point. Avoiding an unnecessary prophylaxis. You're right, the MRI is central, and starting dexamethasone for symptoms is key. Teaching pearl. Now, just a side note here. While we avoid routine prophylaxis, remember that location matters. A right frontal lesion, especially near the motor cortex, like this one probably is, it's quite epileptogenic. If this were, say, in the temporal lobe, which has the highest risk, I'd be extra vigilant in counseling, even though the guideline itself wouldn't change. Just something to keep in mind. Okay, moving on. The preoperative MRI reveals a 4.5 centimeter ring-enhancing mass in the right frontal lobe abutting the precentral gyrus. A postoperative MRI within 24 hours shows no residual enhancement. Pathology shows a high-grade astrocytic neoplasm with microvascular proliferation and pseudopalisading necrosis. IDH1 R132H wild type, MGMT unmethylated, and ATRX intact. What is the integrated diagnosis and the key prognostic factors?
Okay, the integrated diagnosis is glioblastoma IDH wild type, CNS WHO grade 4. That's based on the WHO CNS 5 criteria. Basically, any diffuse astrocytic glioma that's IDH wild type automatically gets classified as grade 4, regardless of the old histological grading. And yeah, the WHO classification of grade, that's what we use now instead of TNM staging for these diffuse gliomas.
And MGMT, why is unmethylated bad?
Right. So MGMT unmethylated is a major negative prognostic factor. MGMT stands for 06-methylguanine DNA methyltransferase. It's a DNA repair enzyme. When the promoter for that gene is methylated, the gene gets silenced. The protein isn't made. So the tumor cells can't repair the DNA damage caused by alkylating agents like temozolomide or TMZ that makes them sensitive to the drug. But when the promoter is unmethylated, like in this case the gene is active, MGMT protein is expressed at high levels, and the tumor cells are very efficient at repairing the TMZ-induced DNA damage. This makes the tumor fundamentally resistant to TMZ, and it translates directly to shorter progression-free and overall survival. It's a key biomarker. So the key prognostic factors are age, KPS, extent of resection, and MGMT promoter methylation.
Excellent explanation of the mechanism. So, given this tough situation, GBM, IDH wild type, MGMT unmethylated, what's your definitive recommendation for adjuvant therapy? And what's the level 1 evidence that tells us we still need to treat aggressively even in this less favorable group?
Even with the unmethylated status, my recommendation is still the STOOP regimen. That's concurrent chemoradiation followed by typically 6 cycles, maybe up to 12, of adjuvant temozolomide.
And the evidence?
The evidence is the landmark EORTC 22981 NCIC CE.3 trial. Everyone just calls it the STUP trial. It compared standard radiotherapy 60 grays and 30 fractions versus that same RT plus concomitant daily TMZ followed by adjuvant TMZ cycles. The combined chemo-RT arm significantly improved median overall survival. It went from 12.1 months to 14.6 months. Now, you might say that's modest, but critically. The trial subgroup analysis showed a survival benefit across all predefined subgroups, including those patients with unmethylated MGMT status. The absolute benefit was smaller in that group, sure, but it was still there. And maybe even more importantly, look at the long-term survival. The 5-year survival rate shot up from just 2% with RT alone to about 10% with the STUP regimen. That tail on the Kaplan-Meier curve, that 10% of long-term survivors, is why STUP remains the standard of care. You can't perfectly predict who will be in that 10% based on MGMT alone, so you got to give everyone the chance.
Precisely. The STOOP protocol remains standard even in unmethylated disease, though the absolute benefit is smaller. Okay, let's drill down into the radiation planning itself. Outline the simulation setup, the dose and fractionation, your target volumes, GTV, CTV, PTV, and the critical organ at risk, or OAR, constraints for this GBM plan. Justify those margins too.
All right, for simulation, patients can be supine, immobilized in a custom thermoclastic mask for reproducibility. We'll get a CT scan for planning, ideally thin slices, maybe 1 to 2 millimeters, and that CT gets fused using rigid registration to both the preoperative MRI and, most importantly, the postoperative MRI sequences. Got to have good fusion. The standard dose is still 60 gray, delivered in 30 fractions over 6 weeks. And we'd use advanced techniques like IMRT or VMAT to get a highly conformal dose distribution and spare normal tissues.
And the volumes, how do you define them?
For volumes, I'd follow the EORTC Estro consensus guidelines. Pretty standard now. The gross tumor volume, the GTV, is defined as the surgical resection cavity plus any residual enhancing tumor seen on that postoperative T1 post-contrast MRI.
The clinical target volume, or CTV, is where the microscopic disease is expected. That's generally the GTV plus a 1.5 centimeter margin. But critically, you have to edit that margin respect anatomical barriers. Things like bone, the falx, tentorium, sometimes even major white matter tracts, or deep sulci if it makes sense. You don't just do a uniform expansion. Historically, people used maybe 2 or even 3 centimeter margins, but we know now that over 90% of GBM recurrences happen within about 2 centimeters of the original enhancing lesion. So that 1.5 centimeter margin, combined with conformal RT, is now standard. It balances coverage and toxicity. And then the planning target volume, PTV, is just a small expansion on the CTV to account for setup uncertainty and daily motion, typically around 3 to 5 millimeters. For OAR constraints, the optic nerves and KAI as ZEM, the maximum point dose, Dmax, should be kept less than or equal to 54, maybe 55 gray. That's to minimize the risk of radiation-induced optic neuropathy, which is obviously devastating. For the brainstem, the Dmax constraint is also usually 54 gray. Although depending on exactly where the tumor is, sometimes a very small volume like less than 0.1 cc might receive up to 59 gray if it's absolutely necessary for PTV coverage, but you really try to avoid that. Generally, 54 gray max is the goal, and increasingly important, especially now that patients are living longer, is the cochlea. We aim to keep the mean dose to the cochlea less than or equal to 45 gray, particularly on the side with better hearing to reduce the risk of sensorineural hearing loss.
Excellent. And you highlighted the evolution to smaller margins. That's entirely driven by understanding patterns of failure, knowing that GBM recurrence is overwhelmingly local. But the flip side, is the accuracy of that initial GTV definition based on high-quality fused MRI and CT becomes absolutely paramount. If you miscontour the GTV even slightly, you risk a marginal miss, which is tough to salvage. A key board pearl is that smaller, conformal fields keyed to T1 enhancement plus margin are endorsed in modern guidance. Most failures remain local. Okay, during treatment with the STOOP regimen, what are the common acute toxicities? And specifically, what's the most critical mitigation strategy you need to implement, especially because of the concurrent TMZ? And then what's your standard post-RT imaging schedule?
Right. Acute toxicities. It's a mix. Patients all get significant fatigue. There's localized dermatitis and hair loss, alopecia within the radiation field. And then systemically, from the temozolomide, you worry about myelosuppression, especially lymphopenia, but also neutropenia and thrombocytopenia. We manage the systemic stuff with, scheduled antiemetics because TMZ can cause nausea. And critically, weekly CBC labs during that entire 42-day concurrent phase to monitor blood counts.
And the most critical mitigation.
The absolute must-do, non-negotiable mitigation strategy during concurrent chemo-RT is pneumocystis jirovecii pneumonia, or PJP, prophylaxis. It used to be called PCP. This is actually required per the temozolomide drug label. It's essential because the combination of radiation, the daily TMZ, and often concurrent or recent steroids leads to significant T-cell depletion, specifically lymphopenia. That puts patients at high risk for PJP, which can be fatal. So you have to start prophylaxis, usually with TMP-SMX Bactrim, right when concurrent therapy begins and continue it throughout.
Crucial point. And surveillance after treatment.
Post-treatment surveillance starts pretty quickly. The first follow-up brain MRI is typically ordered about 4 weeks after finishing the 6 weeks of concurrent chemoradiation. That timing helps establish a new baseline before starting adjuvant TMZ cycles. If that first scan is stable or improving, the standard cadence afterwards is usually an MRI every 2 to 3 months for the first 2 years. That's the period of highest risk for recurrence. After 2 years, if things remain stable, you might start extending the surveillance interval maybe to every 4 months, then every 6 months.
Perfect. That PJP prophylaxis point is absolute core knowledge. Okay, let's transition to some nuances we often encounter. We just talked about that first post-RT scan. Let's quickly revisit pseudoprogression. Remind us of the basic pathophysiology. Why does this happen? And why might we actually see it more often in patients who are responding well to treatment?
Right, pseudoprogression or PSP. It's essentially a treatment effect, not true tumor growth. What happens is the chemoradiation causes significant tumor cell death and damage. This triggers a pretty robust inflammatory response in the surrounding brain tissue. All that inflammation leads to increased vascular permeability, basically making the blood-brain barrier leaky in that area. So when you inject a gadolinium contrast for the MRI, it leaks out into the tissue and enhances looking like tumor progression, but it's really just inflammation and treatment.
And why more common with good response?
It's thought to be more common in patients with a good response, particularly those with MGMT methylated tumors who are more sensitive to TMZ, precisely because there's more tumor cell kill happening. More cell death means a bigger inflammatory cascade, more BBB breakdown, and thus a higher likelihood of seeing that enhancement pattern that mimics progression. It's kind of a paradoxical sign of treatment working, in a way.
A key teaching pearl is that the 12-week post-radiation therapy window is the pseudoprogression danger zone. Continue therapy and re-image unless there's clear deterioration. Let's say it's 6 weeks after finishing concurrent chemo-RT. You get the first MRI back. It shows a 40% increase in the size of the enhancing lesion compared to the immediate post-op scan. But clinically, the patient feels fine, totally asymptomatic. How do you interpret this finding, and what's the next step?
Okay, 6 weeks post-RT, new enhancement increase, but patient is asymptomatic. This is classic timing and presentation for pseudoprogression. We're well within that critical first 12-week window after completing RT. According to the RANO criteria response assessment in neuro-oncology, you cannot definitively call true tumor progression based solely on imaging changes within these first 12 weeks unless there's clearly new enhancement outside the radiation field, or you somehow get pathology confirming recurrence. So given he's asymptomatic, the strong suspicion is PSP. The next critical step is do not stop treatment. You continue the planned adjuvant temozolomide cycles as scheduled, and you repeat the brain MRI probably in about 1 to 2 months to see how it evolves. Time is often the best diagnostic tool here.
Right, using time as the differentiator. What if, after that next scan, you're still uncertain? Are there advanced imaging techniques that can help distinguish PSP from true progression?
Yes, definitely. If the enhancement persists or looks worse on the follow-up scan and you're still not sure, advanced MRI techniques can be really helpful. MRI perfusion, specifically measuring relative cerebral blood volume or RCBV, is useful. True tumor recurrence is typically hypervascular and will show high RCBV. Pseudoprogression, being mostly inflammation and edema, usually shows low or normal IXDBV. Another tool is MR spectroscopy. It looks at metabolites. True progression often shows an elevated choline peak, reflecting high cell membrane turnover. PSP, on the other hand, might show decreased choline or maybe elevated lactate or lipids if there's necrosis. These aren't perfect, but they add valuable information to help stick to the RANO guidelines and avoid stopping effective therapy prematurely.
Good summary of the advanced tools. Now, let's flip the clinical picture. Same imaging finding 40% increase in enhancement at 6 weeks, but this time the patient is symptomatic. Maybe new onset confusion, significant functional decline, clearly related to the edema around this enhancing area. How does your management change?
Okay, symptomatic patient changes things significantly. The immediate priority shifts to managing the symptoms caused by the vasogenic edema. First step is almost always corticosteroids, start or increase the dose of dexamethasone, aiming for rapid symptomatic relief. While doing that, you'd likely still continue the planned adjuvant TMZ, assuming the suspicion for PSP remains high. However, if the symptoms are severe, or if they're refractory to high doses of steroids, or if the patient starts having unacceptable steroid side effects, that's when you consider bringing in bevacizumab. Bevacizumab, the anti-VEGF antibody, is very effective at reducing vascular permeability. It can often provide rapid symptomatic relief from vasogenic edema, sometimes within days, even if the underlying process is PSP. It basically plugs the leaky vessels. It's a key tool for managing symptomatic presumed PSP.
All right, let's pivot to a common clinical challenge, treating elderly patients. New case twist. We have a 73-year-old woman, same diagnosis, GBM, status post-GTR, and her KPS is also good, KPS 80. But here's the difference. Her tumor's MGMT promoter is mesylated. What are the main treatment options for her, considering her age and favorable MGMT status? And what would be your default recommendation for this reasonably fit elderly patient?
Okay, 73 years old, KPS 80, but MGMT methylated. That methylated status is key. It predicts a much better response to temozolomide, which really opens up our options, especially in the elderly. So the main evidence-based options are basically three. One, hypofractionated radiation with temozolomide. This is often called the PERI regimen, based on the NCIC CE.6 trial. It uses 40 gray in 15 fractions, such as 3 weeks of RT, combined with concurrent and adjuvant TMZ. That trial showed a median OS of about 13.5 months, specifically in the methylated elderly group getting this combo. 2, temozolomide monotherapy, just TMZ chemotherapy alone. This is supported by 2 big trials, the NOA-08 trial from Germany and the Nordic trial. It showed that in elderly MGMT methylated patients, TMZ alone was non-inferior, maybe even slightly better than RT alone. 3, you could consider the standard Stupper regimen 60 gray in 30 fractions with TMZ. But that's 6 weeks of daily treatment, potentially more toxic and generally less favored in the elderly population, even if they are fit.
Okay, so those are the options. What's your recommendation for this KPS 80 patient?
Given her good performance status, KPS 80, my default recommendation would be option 1, the PERI regimen. That's the hypofractionated RT, 40 GCO in 15 fractions, with concurrent and adjuvant TMZ. It really seems to offer the best balance. You get the proven benefit of combining radiation and chemotherapy, capitalizing on that MGMT methylation, but with a much shorter, more convenient, and generally better tolerated radiation schedule compared to the full 6-week STEP protocol. It optimizes efficacy while considering quality of life.
Makes sense. That's often the standard now. So when would you choose option 2, the TMZ monotherapy, instead of the PERI regimen? What kind of patient profile fits that approach?
TMZ monotherapy becomes a really strong consideration for the more frail elderly patients. I'd lean towards it if the patient had a lower KPS, say 60 or 70, or maybe significant comorbidities that would make daily radiation for 3 weeks difficult. Also, patient preference plays a role. If someone strongly wishes to avoid radiation and its potential side effects, or if the logistics of daily treatment are a major barrier, TMZ monotherapy is a very reasonable alternative, specifically because we know from NOA-08 and Nordic that it performs well in this methylated group. It's less.
Got it. Let's stick with the PERI regimen for a moment. Say this 73-year-old patient starts the concurrent phase, 40 gray in 15 fractions, with daily TMZ, and she develops grade 3 thrombocytopenia. Platelets drop below 50,000. how do you manage that hematologic toxicity? What's the priority?
Okay, grade 3 thrombocytopenia during concurrent treatment. The absolute priority here is completing the planned course of radiation therapy without interruption. The RT is providing the primary local control. So I would immediately hold the concurrent temozolomide. I'd increase monitoring, check her CBC maybe twice a week, wait for a platelet count to recover to a safe level, usually above 100,000. Once her counts are back up, I would resume and complete the remaining fractions of radiation therapy, but without restarting the concurrent TMZ for that cycle. You don't want to risk further delays to the RT. Then when it's time to start the adjuvant TMZ cycles after RT is done, I would definitely start the first cycle at a reduced dose, maybe a 20 or 25% reduction, and monitor her counts very closely.
Teaching Pearl. Perfect. That's the key principle when managing concurrent chemo RT toxicity for GBM. Radiation takes precedence. You hold the chemo, adjust it later, but you do everything possible to deliver the full radiation dose on schedule. Let's step back to the general GBM population for a second. Imagine a younger, fit patient who has just completed the standard STIP protocol. Regardless of their MGMT status, what additional adjuvant therapy should you absolutely discuss with them now? And what are the critical counseling points about using it effectively?
For any reasonably fit GBM patient starting adjuvant temozolomide after concurrent chemo RT, you absolutely have to discuss adding tumor treating fields or TT fields. The evidence is strong, mainly from the EF14 trial. That trial randomized patients after chemo RT to get adjuvant TMZ alone versus adjuvant TMZ plus TT fields. The results were pretty striking. Adding TT fields significantly improved median overall survival from 16.0 months to 20.9 months. And it also boosted 5-year overall survival from 5% to 13%. That's a meaningful difference.
Definitely meaningful. What are the catches? What do you need to emphasize when counseling?
The big thing with TT fields is compliance. It's not a drug you take, it's a device you wear. It works by delivering these low-intensity electrical fields through arrays placed on the scalp, which disrupts cancer cell division. But for it to work like it did in the trial, patients need to wear the device for at least 18 hours per day. That's a huge commitment. You have to counsel them about the logistics, managing the device, the battery packs, wearing it constantly. And critically, you need to proactively manage scalp care. Those transducer arrays are stuck to the scalp, changed every few days, and they can cause significant skin irritation or breakdown if not managed properly. So you need a plan for scalp hygiene, maybe topical steroids. It's a therapy that requires a lot of patient buy-in and support.
Okay, let's shift gears now. Case 3. We have a 42-year-old woman presents with her first ever generalized seizure. Otherwise healthy, KPS is 90. MRI shows a non-enhancing 4-centimeter T2 flare hyper-intense mass in the left temporal lobe. What is your initial management?
My initial management involves supportive care and establishing a definitive diagnosis. Since she presented with a seizure, I will start an anti-epileptic drug, favoring a non-enzyme-inducing agent like levetiracetam. I will obtain a neurosurgery consultation for maximal safe resection, which is critical for diagnosis, symptom control, and prognosis.
Excellent. For a new seizure-presenting brain mass, levetiracetam is the preferred anti-epileptic drug because it does not interfere with the metabolism of chemotherapy agents. She undergoes a gross total resection. Pathology shows an astrocytoma with increased cellularity and mitotic activity. Molecular analysis reveals an IDH1 mutation, loss of ATRX, and no 1p19q codeletion or homozygous CBKN2A and B deletion. What is the diagnosis and her expected prognosis?
Okay, 42-year-old, GTR IDH1 mutant ATRX loss, 1p19q intact. The integrated diagnosis is astrocytoma, IDH mutant, CNS WHO grade 3. The IDH mutation makes it at least grade 2, and the histological features here push it to grade 3. The ATRX loss confirms its astrocytic lineage, not oligodendroglial. If it had homozygous CDKN2AB deletion, that would automatically bump it to grade 4, but it doesn't. Prognosis here is intermediate. It's significantly better than IDH wild-type GBM, but not as good as the 1p19q code-deleted tumors. With optimal therapy, median overall survival is generally in the range of, say, 6 to 8 years, maybe longer now with modern treatments.
Okay, and the treatment? Based on what evidence?
The treatment recommendation is based squarely on the results of the Cat-non trial. That trial specifically looked at anaplastic gliomas without 1p19q codeletion, so mostly IDH mutant astrocytomas like this one. It tested RT alone versus RT with concurrent TMZ versus RT followed by adjuvant TMZ versus RT with both concurrent and adjuvant TMZ. The key finding was that the survival benefit was driven entirely by the adjuvant temozolomide. Adding concurrent TMZ to RT didn't improve survival, but did add toxicity. Comparing RT alone to RT followed by 12 cycles of adjuvant TMZ, the median OS jumped significantly. It was something like 47 months versus 82 months. Big difference. So my recommendation is radiation therapy, typically to 59.4 grays and 33 fractions, that's 1.8 GD per fraction, followed by 12 cycles of adjuvant temozolomide.
Interesting. Can you elaborate just a bit on why that might be? Why did concurrent TMZ help so much in the STUT trial for GBM, but not here in CATN for IDH mutant astrocytoma?
Yeah, it's a fascinating difference, likely related to the underlying biology. IDH wild-type GBM is very aggressive, rapidly proliferating. Concurrent TMZ seems to provide crucial radiosensitization in that context, making the RT more effective up front. IDH mutant gliomas, even grade 3 ones, tend to have a slower biological tempo. They're also intrinsically more sensitive to alkylating chemotherapy like TMZ. So in this population, it seems the prolonged systemic pressure from 12 months of adjuvant therapy is what really drives the long-term benefit. The upfront radiosensitization from concurrent TMZ just didn't add enough to overcome the benefit of the extended adjuvant treatment, and it came with extra side effects. The biology dictates the optimal sequencing.
A superb synthesis of the data. The CATNON trial definitively showed that for IDH mutant anaplastic astrocytomas, the survival benefit is driven by adjuvant TMZ, not concurrent. How do your target volumes for this tumor differ from those for a GBM?
These tumors are more infiltrative along white matter tracts. That non-enhancing flare abnormality on the MRI often represents tumor infiltration. So, for the IDH wild-type GBM, remember our CTV was focused tightly around the T1 enhancement plus a 1.5 centimeter margin. For this grade 3 IDH mutant astrocytoma, the CTV needs to be significantly larger to account for that infiltrative nature. Typically, the CTV would encompass the resection cavity and the bulk of the preoperative T2 flare abnormality, often with a generous margin, maybe 15 millimeters or even more for grade 3 disease, again carefully edited for anatomical barriers.
An important distinction. Compared with GBM, grade 3 astrocytoma planning often includes more of the FLAR disease, with a larger CTV margin to account for its more infiltrative nature. What are the key toxicities of prolonged adjuvant temozolomide, and what is your surveillance plan?
The primary toxicities are cumulative myelosuppression and fatigue. I will monitor a CBC before each cycle and dose reduce or hold treatment based on blood counts. For surveillance, I will obtain a brain MRI every 3 to 4 months for the first 2 years, then space out to every 6 months if she remains stable.
A solid plan. Long-term adjuvant TMZ requires vigilant hematologic monitoring to manage cumulative myelosuppression and ensure completion of therapy. Okay, here's a twist that happens sometimes. The molecular pathology report is finalized a bit later, and the pathologist calls you. Turns out, despite the initial histology looking like grade 3 astrocytoma, the final molecular testing shows it is definitively IDH wild type. How does that single piece of molecular data change your diagnosis and your entire management plan?
Well, okay, this molecular finding fundamentally changes the diagnosis to glioblastoma, IDH wild type, CNS UWHO grade 4. I would therefore recommend the full STUP protocol. Concurrent radiation to 60 gray in 30 fractions with daily temozolomide, followed by at least 6 cycles of adjuvant temozolomide, and I would discuss adding tumor-treating fields.
Correct. Molecular markers trump histology. A histologically grade 3 astrocytoma that is IDH wild type is reclassified as a CNS WHO grade 4 glioblastoma and should be treated as such. Let's move to our third type of high-grade glioma, the oligodendrogliomas, specifically the ones with the favorable marker. Case 4. A 50-year-old man presents with personality changes and difficulty with executive function. An MRI reveals a large, partially calcified, heterogeneously enhancing mass in the left frontal lobe. What are the next steps in his workup?
Given the location and radiographic features, my differential includes a high-grade glioma, likely an oligodendroglioma given the calcifications. I would start him on a course of dexamethasone. The most critical next step is a neurosurgical consultation for maximal safe resection to establish a tissue diagnosis, relieve mass effect, and provide initial site reduction. I will also obtain baseline labs.
Correct. Calcification on imaging in an adult with a new brain mass is suggestive, though not pathognomonic, of an oligodendroglial tumor. He undergoes a subtotal resection. Pathology shows a WHO grade 3 oligodendroglioma. Molecular testing confirms an IDH1 mutation and 1p19q co-deletion. KPS is 90. What is his expected prognosis?
Okay, diagnosis is anaplastic oligodendroglioma, IDH mutant, 1p19q co-deleted, CNS WHO grade 3. That molecular signature, the combination of IDH mutation and 1p19q co-deletion, is incredibly important. It confers a remarkably favorable prognosis, especially for a high-grade glioma. These patients have the best outcomes. Expected median overall survival is now reported in the range of 14 to 15 years, maybe even longer, with optimal therapy. It's a dramatically different disease than GBM or IDH mutant astrocytoma.
Exactly. The combination of IDH mutation and 1p19q co-deletion defines a molecular oligodendroglioma and is one of the most powerful positive prognostic markers in neuro-oncology. State your regimen, cite the relevant trials, and discuss the sequencing of modalities.
The standard of care treatment is radiation therapy plus PCV chemotherapy. The evidence for this comes from the long-term follow-up reports of two major randomized trials.
EORTC 26951 on adjuvant PCV and RTOG 9402 on neoadjuvant PCV.
Both trials compared RT alone versus RT, followed by PCV chemo in patients with anaplastic gliomas. The initial reports were kind of mixed, but the crucial long-term updates showed that the significant overall survival advantage for adding PCV was seen only in the subgroup of patients whose tumors had the 1p19q's co-deletion. So for this patient, the recommendation is RT, usually 59.4, gray, and 33 fractions, combined with PCV chemotherapy. In terms of sequencing, while both concurrent and adjuvant PCV were studied, adjuvant sequencing doing the RT first, then giving 6 cycles of PCV is generally preferred now as it tends to be better tolerated.
Teaching Pearl, right? PCV is the regimen. Procarbazine, CCNU, which is lomustine, and vincristine. It's highly effective in this setting, but notoriously toxic. Can you name 2 specific common pitfalls associated with PCV that you definitely counsel the patient about, things that might threaten their ability to complete all 6 cycles?
Yes, PCV has some distinct toxicities you really have to watch for. First is the vincristine-induced peripheral neuropathy. This is very common, often starts as tingling in fingers and toes, but can progress to painful neuropathy or even motor weakness. It's cumulative. You have to monitor for it closely in each cycle, often reduce the vincristine dose, or even omit it entirely if neuropathy becomes significant because it can't become permanent. Second is the profound and often delayed myelosuppression caused by the CCNU, the lomustine component.
CCNU is a nitrosuria, and its nadir, the lowest point for blood counts, can occur quite late, sometimes 4 to 6 weeks after the dose. It's also cumulative, meaning the suppression can get worse with each cycle. This requires very careful CBC monitoring between cycles, often needing dose reductions or delays, and it can be quite taxing on the patient and limit completing all 6 cycles.
Perfect. For anaplastic oligodendrogliomas, combined radiation and PCV chemotherapy is the standard of care, offering a median survival exceeding 14 years. Outline your radiation therapy planning details.
I would plan radiation to 59.4 gray in 33 fractions using IMRT or VMAT. My GTV would be the surgical cavity plus any residual T2 flare and enhancing disease. My CTV would be a 1 to 1.5 centimeter anatomically edited expansion.
Good points on PCV toxicity. Okay, let's fast forward. 5 years later, this same patient, now 55, develops a recurrence. It's a focal, 2.5 centimeter enhancing lesion, clearly located within his original radiation therapy field. He's remained active, KPS is still 90, he had a nice 5-year disease-free interval. What are the management options now for this recurrence, and what approach would you generally favor?
Okay, fit patient, focal infield recurrence after long disease-free interval. This is a situation where local therapy should definitely be considered first. The main options are 1. Re-resection, if the lesion is in a surgically accessible location and the neurosurgeon thinks it's feasible. 2.
Reirradiation, delivering another course of focused radiation to the recurrence. 3. Systemic therapy, maybe switching to temozolomide or potentially even re-challenging with CCNU-based chemo, though options become limited. My favorite approach would be strongly multidisciplinary, but given his fitness and the focal nature, I would prioritize re-resection if it's deemed safe and feasible. Getting tissue confirmation and achieving cytoreduction would be ideal. Depending on the resection results, you might then consider adjuvant systemic therapy or potentially reirradiation to the bed. If resection isn't an option, then reirradiation becomes a primary consideration.
Let's focus on reirradiation, as that's our domain. There is prospective data supporting it now, like from RTOG 1205. If you decide to proceed with reirradiation, what kind of dose and fractionation regimen would you typically use? And how do you approach the critical issue of cumulative dose constraints, especially for structures like the brainstem or optic nerves?
Right, reirradiation is a viable option, especially with the modern conformal technique. The RTOG 1205 trial investigated bevacizumab, with or without reirradiation, using 35 gray and 10 fractions, and showed a PFS benefit for adding re-RT. So a common regimen is indeed 35 gray and 10 fractions, delivered over 2 weeks, or a similar hypofractionated schedule, using highly conformal techniques like SRS, fractionated stereotactic RT. Planning is extremely meticulous. The target volume is kept very tight. The GTV is just the recurrent enhancing lesion, maybe with a tiny 0 to 2 millimeter PTV margin. You really want to minimize the volume getting a second high dose. The major challenge is assessing and respecting cumulative dose limits. You have to retrieve the original RT plan, to formally register it with the new plan, and sum the doses, usually by converting both plans to an equivalent dose in 2 gray fractions, or EQD2, using the linear quadratic model. This gives you a better estimate of the total biological dose delivered over the patient's lifetime. For critical structures, we rely on published tolerance estimates, though they often come from heterogeneous data. For the optic nerves and chiasm, the goal is generally to keep the lifetime cumulative maximum point dose below approximately 60 gray EQD2. For the brainstem, the cumulative maximum dose is often aimed to be below about 64 gray EQD2, maybe even lower if possible. It requires extreme caution and careful plan evaluation.
Teaching Pearl, exactly. Reirradiation is feasible, supported by data, but it demands exceptional planning skill and careful patient selection to balance the potential benefit against the real risk of severe light toxicity.
Okay, final block. A 45-year-old man presents with new onset seizures. MRI shows a fairly large 5-centimeter non-enhancing mass that's bright on flare sequences. He undergoes a subtotal resection, STR. Pathology comes back diffuse astrocytoma, IDH mutant CNS WHO grade 2. His KPS is good at 90. First, how do you risk stratify this patient according to standard criteria? And based on that risk stratification, what is your evidence-based management?
45 years old, STR of an IDH mutant grade 2 astrocytoma. Based on the classic RTOG prognostic factors for low-grade glioma, this patient falls squarely into the high-risk category. He meets 2 criteria: age 40 or older, he's 45, and having had a subtotal resection, not a gross total resection. Astrocytoma histology used to be a third factor, but age and extent of resection are the main ones now. Because he's high risk, adjuvant therapy is definitely indicated immediately after he recovers from surgery. Observation is not appropriate here.
And what therapy? What's the evidence?
The evidence comes from the landmark RTOG 9802 trial. This trial specifically enrolled high-risk LGG patients, just like this man. It randomized them to receive radiation therapy alone versus RT, followed by 6 cycles of PCV chemotherapy. The results were striking. Adding PCV chemotherapy after RT significantly improved median overall survival. It went from 7.8 years in the RT alone arm to 13.3 years in the RT plus PCV arm. That's a huge survival benefit, one of the largest seen in neuro-oncology trials. So my recommendation for this high-risk patient is adjuvant radiation therapy, typically to 54 gray and 30 fractions. That's the standard LGG dose, slightly lower than for high grade, followed by 6 cycles of PCV chemotherapy. And of course, since he presented with seizures, he needs to be maintained on appropriate anti-epileptic medication, like levetiracetam.
Excellent application of risk stratification and evidence. For high-risk, low-grade gliomas, RTOG 9802 established radiation followed by PCV chemotherapy as the standard of care, significantly improving overall survival.
Okay, let's contrast that with a low-risk scenario. Case twist. We have a 32-year-old woman, totally asymptomatic, tumor found incidentally perhaps. She undergoes a gross total resection GTR of a smaller 2.5 centimeter frontal lobe lesion.
Pathology shows oligodendroglioma, IDH mutant, 1p19q co-deleted, CNS WHO grade 2, her KPS perfect 100. What's the preferred management strategy for this young, asymptomatic, completely resected, molecularly favorable low-risk patient?
This is the opposite end of the spectrum, the ideal low-risk LGG profile. Young patient under 40, GTR achieved, and she has the highly favorable oligodendroglioma genotype with IDH mutation and 1p19q co-deletion. Here, the essential question is immediate adjuvant therapy versus active surveillance or observation. The key trial informing this is EORTC2-2845. This trial randomized low-risk LGG patients, defined slightly differently back then but generally applicable, to receive early postoperative RT versus observation with RT delayed until the time of progression. The long-term results show that while early RT significantly improved progression-free survival, PFS, it delayed recurrence. It did not provide an overall survival OS benefit compared to delaying RT. So, given her young age, excellent prognosis due to GTR and favorable moleculars, and the goal of deferring potential long-term toxicities of treatment, especially neurocognitive effects from RT, the preferred strategy for this low-risk patient is active surveillance. That means regular follow-up with serial brain MRIs, typically every 3 to 6 months initially.
Okay, active surveillance. What specific findings on those surveillance MRIs or clinically would trigger you to stop observing and initiate treatment? And what would that treatment be?
You'd initiate treatment based on clear evidence of objective tumor progression. Radiographically, that would mean a significant unequivocal increase in the size of the non-enhancing T2 FLI abnormality, often defined as something like a 25% increase in diameter or volume compared to the stable baseline, or, importantly, the definite emergence of new contrast enhancement within the lesion, which often signifies progression or potential malignant transformation. Clinically, the triggers would be the development of new or clearly worsening neurological symptoms attributable to the tumor, or perhaps seizures becoming refractory to medical management if she were to develop them later. If any of those triggers are met, she essentially moves into the high-risk category by virtue of progression, and the treatment then would be the same as we discussed for the initially high-risk patient. RT-254 gray followed by PCV chemotherapy, based on the 9802 data.
Excellent. The threshold to begin treatment in an observed low-grade glioma patient is objective progression, at which point they are treated with curative intent based on high-risk protocols. One final but critical question for counseling these patients choosing observation. Does delaying the RT and chemotherapy until progression increase the risk of the tumor transforming into a higher grade, more malignant glioma later on?
That's a really important question, and thankfully the answer appears to be no. A malignant transformation, unfortunately, is part of the natural history for many diffuse low-grade gliomas over time. However, the long-term data from that same EORTC 22845 trial explicitly showed that the strategy of delaying radiation therapy until the time of progression did not result in a higher rate of malignant transformation compared to giving radiation therapy early. So we can reassure patients that by choosing observation, they are gaining potentially years of high-quality life free from treatment side effects, without apparently increasing the risk of the tumor turning bad faster than it might have otherwise.
A critical point backed by evidence. While malignant transformation is a major concern in low-grade glioma, Level 1 evidence shows that delaying radiation until progression does not increase this risk. All right, that brings us to the end of our case-based run-through of gliomas. We've hit 5 pretty complex scenarios covering everything from newly diagnosed GBM and its nuances through the different types of IDH mutant high grades down to risk stratification and observation in low-grade gliomas. Let's just take a moment to quickly recap some of the overarching key integrated learning points that really define modern practice in this area.
Yeah, I think the absolute foundation now is the necessity of getting that integrated WHO CNS5 diagnosis. Really understanding that molecular markers, IDH status, 1p19q co-deletion, MGMT methylation are often the most powerful prognostic and predictive factors, sometimes even overriding the traditional histology. We have to think molecularly first. And related to that is the critical importance of managing potential pseudoprogression using the RANO criteria. We can't afford to stop effective therapy too early just based on ambiguous imaging changes in that post-RT window. Stick to the criteria, use advanced imaging or time as needed.
Absolutely. And we reinforce the core principles of risk stratification, how factors like MGMT methylation in an elderly GBM patient can open the door to less intensive but still effective options like the Peri regimen or even TMZ monotherapy. We also highlighted the very different radiation target volumes required for those highly infiltrative IDH mutant astrocytomas versus the more focal approach for IDH wild-type GBM.
And maybe one final consistent clinical theme that came up, especially when dealing with concurrent therapies like chemo-RT for GBM or PCV toxicity, is the priority of completing the full planned course of radiation therapy whenever possible. You manage the systemic toxicity, you might have to hold or reduce the chemo temporarily, but securing that local control foundation with the full RT dose is paramount.
Fantastic summary. You navigated all that evidence and the nuances really well today. I think that was an excellent session, really good practice for thinking through these cases at an advanced level.
Thank you. It was helpful to walk through it systematically. That level of detail, connecting the trials to the specific patient scenarios, is exactly what you need for clinical practice and, for boards.
Definitely. For everyone listening, you can find show notes and links to additional practice questions related to these cases over at radoncSmartLearn.com. Be sure to subscribe to Rad Onc Smart Review so you don't miss our next series. Thanks so much for tuning in.